the presentation from Spinogenix from Dr. Peter Vanderklish. Peter, please go ahead. Thank you.
Thanks. So the Spinogenix team and I would like to thank the organizers for the opportunity to present our progress in developing a new therapy for ALS, one focused on regenerating glutamatergic synapses. So since the last time we spoke at this conference, we've now entered the clinic. I'm going to give you a snapshot of the clinical plan and the progress we've made so far. But first, I'll start out by revisiting the rationale for targeting synapses in ALS, a bit of the basics of our technology, and some of the preclinical data that we think speak to the potential of our approach in several symptom domains of ALS. So our mission at Spinogenix is to address the synaptopathies. These are conditions in which a loss of synapses, particularly glutamatergic synapses, cause functional declines in cognition and motor function. They're etiologically diverse, as you see in this donut chart. They include the dementias and motor diseases, among which is ALS and FTD. They're often progressive and fatal. Unfortunately, at present, there are no therapies that will reverse synapse loss in any synaptopathy. And we know that synapse slowing progression is just not enough. You need a regenerative approach, something that can reboot synaptic density and hopefully regain lost function. Now, to do this, we are developing a novel platform of small molecules called the SPGs that restore dendritic spine synapses. You can see this effect here in these images. On the left, you have an apical dendrite from the CA1 region of a drug-naive animal. On the right, you see one from a drug-treated animal, one treated with SPGs. Along each of these dendritic segments, you see these small protrusions, about 1 micron in length. These are dendritic spines. They're the postsynaptic element in around 90% of glutamatergic synapses in the mammalian brain. And you can see the one on the right, the SPG-treated animal, has more of these spines. This is the fundamental biological effect of our drugs. They increase the density of spines and functional glutamatergic synapses. So the SPGs have a lot of remarkable properties, actually, as a pharmacology. They're rapid acting via a novel mechanism of action targeting the cytoskeleton. We see new spines within 4 hours or less when we treat with nanomolar, low nanomolar concentrations of drugs. In vivo, we see synaptic and behavioral improvements within weeks in mice, rats, and beagle dogs, 3 species. Remarkably, they require only transient exposure, which prompted the acronym TAGS, transient activators of glutamatergic synaptogenesis. In vitro, you need to expose the neurons to 1 hour or so to get spines. And in vivo, we see efficacy with daily dosing of compounds that have a half-life of only 24 minutes. So these potent, rapid effects, we think, trigger a self-perpetuating and self-limiting process that carries forward on its own to generate physiologically relevant numbers and shapes of new axospinous glutamatergic synapses. And I should note that this has an intrinsic sort of safety mechanism. If we treat longer, or if we treat at much higher doses, we do not ever see too many spines or abnormal shapes of dendritic spine synapses. So in addition to being rapid, potent, and self-limiting, the SPGs induce effects that are durable. In a dog dose range finding study where we treated with SPG 302, our lead compound, for 2 weeks. At 3 dose levels, we investigated spine density 2 weeks after the last dose. And the bottom line is that what we saw was a durable increase in dendritic spine synapses in the motor cortex, apical dendrites, layer 5, and the prefrontal cortex, I should say. Importantly, as you see highlighted in these rectangles, the effects were seen in mushroom-shaped spines. And this is important, one, because it indicates that the spines we induce are functional. These are high-efficacy, durable contacts. And mushroom spines also appear to be the kinds of synapses that are prominently affected in ALS. So there's a lot of data out there in the literature that provide a very compelling case that ALS is a synaptopathy and that synapse loss is a very early and nodal event in the pathogenesis of the disease. Now, the time constraints are such that I can't go into this in high resolution, but I will provide a couple of major landmarks to this data. One is the histological evidence that exists, which is very extensive. So we know from postmortem studies and familial and sporadic cases that there are losses of synapses in the motor cortex, the spinal cortex, and several other brain regions. Now, interestingly, in ALS patients that also have cognitive decline, the degree of synapse loss in the prefrontal cortex is greater, and it's not due to cortical atrophy. It looks like a primary dysfunction. Now, from studies in mouse models of multiple genotypes, we've learned that this synapse loss occurs very early in progression, before symptom onset and before dendritic atrophy, in the motor cortex subcircuits that feed into it and other areas, and around the time of onset, symptom onset in lower motor neurons, and the degree of synapse loss correlates with the relative vulnerability of different lower motor neuron types. Now, other major landmarks of data that are particularly compelling have come out recently include this sort of collaboration, if you will, between UNC13A risk variants and TDP43 pathology, which ultimately ends up resulting in the inclusion of a cryptic exon in UNC13A, which shunts the transcript to nonsense-mediated decay, reducing the expression of the synaptic protein presynaptically and greatly impairing glutamate release. So it has a prominent effect on presynaptic failure. It should be noted in this context that another study in animals showed that nuclear or mislocalization of TDP43 is alone sufficient to drive early and large decreases in dendritic spine synapses, so it's having pre and postsynaptic effects. Other compelling data include recent observations that the C9 repeat expansion, the most common cause of ALS, reduces spine formation and glutamate release in multiple ways, directly through loss of C9 protein and production of dipeptidyl repeats, but also through other effects like impairments in autophagy and such. And then finally, there are a number of omics studies that have been leveraged to look at synaptic effects. And one of these is looking at the synaptic proteome. And the bottom line here is that studies of ALS patient samples, cell lines, and animal models paint a picture of presynaptic failure with postsynaptic compensation in the synapses that remain. So synapses can be lost, but in those that remain, it looks like cells are trying to increase the postsynaptic gain. So altogether, there's a lot of data pointing to synaptic failure as a primary dysfunction in ALS. Now, we're leveraging our technology to try to mitigate this problem. Our lead clinical candidate is SPG302. We're positioning it in ALS. We think we can reverse synapse loss in the disease and hopefully slow or reverse the course of some symptoms. It can be used in principle as a monotherapy or with other emerging therapies. It has excellent drug-like properties. It's highly orally bioavailable via a simple formulation, gets in the brain very well. It has a wide therapeutic window and appears safe and well tolerated. And across a number of different models, we've demonstrated efficacy preclinically in symptom domains relevant to ALS, including motor behavior, cognition, and respiratory motor function. We started phase 1. We've been granted orphan status. So one of the studies that demonstrates the cognitive effects of SPG302 is a study that we did collaboratively with Frank Lafurla's lab at UC Irvine. This was done in the triple transgenic mouse model of Alzheimer's disease. At 6 months of age, this mouse model has profound synaptic deficits in the hippocampus, as well as memory impairment. They treated this mouse at 4 weeks, at 6 months of age for 4 weeks daily with 2 different doses of SPG302, which ended up rescuing synaptic density and hippocampal dependent memories. You can see the synaptic effect on the graphs on the right. And in the first set of columns, you see in total spine density, and you see that both doses of SPG302 return synaptic density to near wild type levels. If you break out by different spine types, you see the effect in mushroom spines and stubby spines. Again, these are high efficacy, durable contacts and contacts that are lost in the ALS brain and spinal cord. Now, looking at respiratory function, we did not test this in an ALS model, but we have tested it in a rodent model, rat model of spinal cord injury. And it's important to note that cervical spinal cord injury impacts breathing. It has several parallels with ALS-related respiratory decline, both symptomatically and mechanistically. We collaborated with the laboratory of Gary Seek and Matt Fogarty at the Mayo Clinic. And there they use a rat C2 hemisection model of spinal cord injury. And that's shown over here to the right in this diagram, the neural sort of chain of command, if you will, of the control of respiration from the brainstem to the spinal cord. And what they do is they go in surgically and they cut at the level of C2, hence the name C2 hemisection, the descending glutamatergic axons from the brainstem to the phrenic motor neurons that control breathing. And this immediately results in a complete abrogation of diaphragm activity as monitored electrophysiologically by diaphragmatic EMG and other measures. So this is a very highly defined in a very highly quantitative model of cervical spinal cord injury. Now, interestingly, about 20% of rats in this model will show some degree of spontaneous recovery, but the bar here is low, as judged by recovery of 15% of the pre-lesion EMG, and this involves synaptogenesis with spared axons, which I think is an informative parallel with ALS. So they treated in this model daily with 302 for 2 weeks, beginning on the day of surgery. And what they found was that SBG 302 profoundly improved the rate of recovery in these rats and the magnitude of recovery. So about 80% of rats, lesion rats, recovered diaphragm activity by day 14 compared to 29% in the placebo group. So SBG 302 greatly improved the rate of recovery. And the magnitude of recovery was about 59% in the drug-treated group, 59% of pre-lesion EMG activity, I should say, and only 20% in the vehicle-treated group. So we think these data actually speak to the potential of our compound to improve respiratory force or rhythm in ALS subjects. Now, we've also tested SBG 302 in a mouse model of ALS. We did this in collaboration with Justin Achita at USC. He was using the TAR44 mouse, a transgenic model that has human TDP43. Mice homozygous for this transgene have an extremely aggressive phenotype. They develop motor symptoms by day 14, and they progress to death within the 4th week postnatal. He started treating with our compound at 15 mg per kg on day 14 when symptoms had already started to emerge, and found that it improved the course of motor symptoms as judged by gait impairment, kyphosis, a hunchback posture the mice adopt when they're weak, and tremor. In each of these graphs you see here, a higher score indicates more impairment. The red lines are SBG 302 treated transgenics, the black lines are the vehicle treated mice. And you can see that SBG 302 treatment, even this very aggressive model, improved the course of motor symptoms. Importantly, it also conferred a survival benefit. So SBG 302 increased the median survival by about 35%, which is remarkable in this model given how aggressive it is. And it's also remarkable from the standpoint that this is SBG 302, as far as we know, doesn't have any intrinsic neuroprotective properties. And so it suggests that the lifespan and motor effects are due to, in fact, the primary synaptogenic effect of the compound. Now, nothing shows an effect like a visual, and to this end, we recorded a video at 22 days postnatal. So you see here 2 transgenic mice, one with a short tail, one with a long tail. The one with the short tail got vehicle, the one with the long tail got SBG 302. And you can see with the one with the short tail, it has splayed legs indicative of weakness. It has a prominent tremor, and it's just having a hard time moving around. It's not ambulating very well. Now, the one that got our drug with the long tail is walking around almost like a wild type mice, not quite, but close. Literally running circles around the one that did not get the drug, and clearly doing much better than the mouse that only received vehicle by 22 days. So dramatic improvement. So we are now in the clinic in a phase 1 clinical trial of SBG 302 testing safety, tolerability, pharmacokinetics, and pharmacodynamics in healthy volunteers and ALS participants. This is a study that has 3 phases to it. It's placebo-controlled, randomized, double-blinded. The first phase is single ascending dose that has 6 cohorts, 5 doses, and also a food effect cohort. It has a multiple ascending dose cohort where patients are treated for 5 days. Our drug does not accumulate day to day, which is why we're treating for only 5 days. In each of the SAD and the MAD phases, we have cohorts with 6 active and 3 placebo per cohort. And then by Q1 of 2024, we hope to start an ALS patient phase where ALS participants will be dosed for 28 days, 9 active and 3 placebo per cohort at doses that are informed by the SAD and MAD data. As you can see by the shading, we've actually made a lot of progress in completing our SAD and our MAD phases of the trial. In the MAD phase of the trial, we have been collecting some PD markers. We have EEG and P300 data under analysis. As we move to the ALS phase, we will be incorporating more outcome measures, motor function, cognitive function, depression, several electrophysiological measures, measures of lung function, and neurofilament light chain. Now, the last phase of the trial, the ALS, will be followed by additional 28-day cycles of SPG-302 treatments for all patients who want it under an open label extension. So this trial is being conducted in Australia at 3 sites run by David Schultz, Dominic Rowe, and Robert Henderson. We're recruiting between the ages of 18 and 80. And our KOLs and our clinicians have advised that we use the TRICALS score to recruit, to enroll. This is a multi-metric scoring system that is a little bit more forgiving, if you will, in terms of symptomatic heterogeneity. And we're using that because we want to be a little bit more inclusive. Patients can't be on other standard of care treatments. We just ask that they have been on that treatment for a month or longer. So we do have some sad data to report that has been reviewed by our safety monitoring committee. And you can see here in this graph, plotting 4 dose response curves for 4 different doses of SPG-302. There's a nice dose proportional exposure and also a negligible food effect, which is not plotted here. This is roughly linear for the AUC and the Cmax values as you go up in dose. Our half-life is about 1 to 2 hours. We see a Cmax in an anticipated range of efficacy, and we're well below the NOAEL. So this is a favorable PK profile consistent with our TAGS mechanism of action, where we induce effects very rapidly, and it's consistent with a wide therapeutic window. Speaking of therapeutic window, in preclinical studies in dogs, we established that the NOAEL is 160 mg per kg. This is equivalent to a human dose of about 5.8 grams, which is well north of anything we would ever intend to dose a human with. You can see this therapeutic window in this AUC plot, this log AUC plot here. It has plotted on it the values we got from the 28-day dog study at multiple doses. You see the NOAEL out here at 160 mg per kg. You see where our various SAD cohorts fall well below the NOAEL. And also plotted here is the AUC that was detected in mice given a dose of 3 mg per kg, which is a dose that was efficacious in the Alzheimer's mouse model. We think doses much lower than that will still be efficacious. Nevertheless, we are within our SAD cohorts are already achieving exposures that we predict to be efficacious and spinogenic. So consistent with a wide therapeutic window and predicted spinogenic exposure levels. Safety-wise, we have seen no severe adverse events. We've only seen 4 grade 1 very mild treatment-related adverse events across 126 doses given. And again, the doses are well below the NOAEL and achieve a plasma exposure consistent with spinogenic activity. So you might ask, why in the ALS cohort in such a short trial would we include so many efficacy outcome measures? You know, we're going to be assessing motor function, cognitive function, respiration, and neurophysiological domains. Why do that in such a short trial when most neurodegenerative disease trials are 6 months or longer? Well, this is prompted by 2 factors. One is our mechanism of action in our preclinical data. So again, remember that we see spinogenesis within hours, and we see benefits in motor, cognitive, respiratory, motor function, and survival domains within days to weeks of treatment. So we expect rapid effects. And it's also prompted by the availability of quantitative readouts that rapidly assess the effects of synaptic regeneration. So this includes TMS to look at cortical hyperexcitability, EEG and P300, all of which are neurophysiological measures that are sensitive to synaptic density. It includes measures of cognition like the ECAS test that captures ALS cognitive deficits and has been shown to be related to synapse loss in the prefrontal cortex of ALS patients. Measures of suicidality and depression that may reveal rapid antidepressant effects similar to those achieved with ketamine or psychedelics, and readily deployed measures of respiratory function that may pick up improvements in respiratory function, force or rhythm, I should say. So the MOA allows us a lot with these very quantitative outcome measures to explore efficacy at relatively early time points. This is a model we're using in the ALS trial, as well as in other indications as we branch laterally into other synaptopathies. So here's where our outcome measures fall in the grand scheme of things in the trial. Of course, our primary concern in this trial is safety. Our secondary outcomes include pharmacokinetics, functional rating scales, measures of lung function. Exploratory outcomes include looking at suicidality and depression, respiratory functional measures, cognitive assessments, neurophysiological measures, including short interval cortical inhibition induced by TMS, EEG, P300s, and looking at blood neurofilament light chain plasma levels. So this is our team. And I would like to thank our management team and our advisors, and thank the organizers for the opportunity to present our data. If you have any questions, please feel free to reach out. And I will reserve for the Q&A maybe a last slide, if anybody wants to talk about the potential of this compound to be disease modifying via synaptic regeneration.
Thank you very much. That's really stimulating, and it's I would argue conceptually a new front in the development of ALS therapy, and really very exciting. I think because we're getting a bit behind schedule now, we'll